Hello?
Hello. Hello.
Hello, hello.
Hey, back again.
Yeah, I'm back again.
Oh, okay. I got to do some things, okay?
Okay, not. Wait for it.
Okay. Hmm. Okay, Joss NC, welcome. Hi, Joss. Can you hear me? Joss, Andy, NC. Joss, are you there? Please introduce yourself, Joss. Okay, whatever. Musinda, we have to teach you how to present.
Yes, yes, I think you can teach me.
Yeah, you can present a case.
Yeah, I think I can.
Yeah. You just gotta practice and get to know some of the other people. Do you know Dr. Kazadi?
I know him in this program.
Yeah. He's a teacher there, right?
Okay, okay.
No.
Okay, I'm trying to figure out. Joss, you may be too young for this program. Hello, Josh. Joss. Well, okay. Well, won't do any harm. I guess just leave there. Yeah, that was a good. They had some good speakers. That conference. I don't know if you saw a lot of it. Did you see a lot of the conference? Musinda, did you see a lot of the conference?
Yeah, today I see a lot of conference today.
Yeah.
I see since
Well, you know, it's good.
6 a.m.
It's just good for you to be around it. The talk, the talk, what they're talking about, and how they approach problems, yeah, and when their
Yeah,
descriptions. You know, you're going to get used to all the language. You're going to get to know it well. It's like speaking a different language.
yes,
Sometimes,
I think. I know.
But here's Marco. He's one of the attendings. Hey, Marco.
Hi, so how are you?
How you doing?
I am pretty fine, thanks. And you?
Good. So your friend was presenting, huh?
Yeah, Maraganao. Yeah, he's a friend of mine.
Oh yeah, you know him, huh?
Yeah, absolutely.
What, you train with him or just know him?
Oh, I just know. He studied in my same university.
Oh,
And
okay.
then we meet each other, but he works in Oxford right now. So it's a long distance from Italy.
Oh, okay. Yeah. Were you surprised to see him, or does he speak a lot?
Yeah. It was a nice panel.
What does he? What's his specialty? What's he?
Especially Mario is spine surgery. He had a fellowship in Toronto, Canada, and he's taking care of head trauma too. As a
So trauma is his specialty.
trauma in Oxford, he take care of the spine surgery and neurotrauma.
Oh, okay. Spine and neurotrauma.
Mm.
Okay. Yeah, they had some really good speakers there. I don't know if you got a chance to watch it.
Yeah, but pretty interesting.
Mr. Chestnut from Seattle, a neurosurgeon from Seattle. Chestnut is his first name. Yeah, let me see if I. But you know, Seattle's program, they're the ones that make those videos. That video chain. I think they have a very strong neurosurgery department.
Oh well, yes, Seattle is very famous for pediatric surgery.
Oh, it is. Yeah, there's a pediatric hospital.
The Seattle Children's Hospital that is completely financed by the Bill Gates Foundation.
Oh, okay. Excuse me. Hey, Musindo, you have a lot of background noise. Hello, Musindo. So I'm going to mute.
Hello.
Yeah, I'm going to mute you, Musindo, because you have a lot of background noise, like a TV. Is there a TV on in the background?
Yeah.
Okay, I'll mute you, okay? It's okay. You don't have to turn TV off.
Okay.
It's okay. I'll just mute you. And when you talk, of course, you got to unmute. Yeah, you know, Marco really went well because we brought in some speakers from Lucindo. I'm going to mute you. Keep it on mute because you have noise in the background. Okay.
Okay.
You have too much noise in the background.
My children, I guess.
Yeah, there's a lot of noise there, but there were the couple Corrado Carino. I'm sure you know him, right?
Correct. Yeah, you told me about him.
Yeah. He does a lot of writing, conferences, and he's very active. He's very active. And there were a couple of other guys that I was really impressed with when I saw him speak. You know how when you go to a conference, you see people that are really good, that have great presentations, really good ones. But yeah, it went well. And
how have you played this streaming, John? There was some friend of you in Pakistan that record the conference for you?
No, well, I worked with some technicians from Pakistan. They were very good. They were very good. I mean, they knew the video, they know the audio, and it was really, really good.
Yeah.
And yeah, it made it easy for me because I just handle the part, that I handle, and that's it. Well, usually, we really have to try hard to get sound and pictures and stuff like that. But it went really well with them. I mean, they were, when when the camera changed, someone else talked, they moved it. So they got the questions. It really felt like a conference. And one of the doctors there was a big doctor from Harvard. His name is Lee Yang, I believe. He's from Korea, but he's the head of the Global Neurosurgery Initiative at Harvard. And and we may have a channel with his presentations, in the global neurosurgery area.
Great.
Yeah. Well, their goal is not education. It's basically to examine standards and make recommendations. It's not like a video channel, but they need to communicate, with the world, and they need to have meetings. And I highly encouraged him, and he was impressed with it. He was first time he was in, and he says, "Wow, this is like being there." Because there he was. He wanted to go to this conference in Pakistan. He couldn't make it, but yet he presented and he interacted with the people there. So he thought, "Wow, this is marvelous."
Yeah, it's great tools.
Yes, I'm surprised he didn't know about it. He's probably pretty technically advanced, but I guess unless you go out of your way, you really wouldn't know too much of it. Naru, are you there? Naru, can you hear me? Hey, Naru.
Hi.
How's it going?
I'm fine, and you?
Good. No camera today?
Yes, let me put my camera. Okay. I'm sorry.
There you go.
Yes. It is good now?
Yep, it's good now.
Perfect.
Nice.
That's your smartphone. That's your laptop, right?
Yes, laptop, yes, because my smart. Hi, Marco. It is long time.
Hey, how are you?
I'm fine. How are you doing?
Oh, nothing special. I'm at rest this weekend.
Nothing special. You went to Mayo Clinic. No, that's not special.
No, outside is raining, so it's not good weather to get out.
Well, actually, you went to Detroit and Mayo Clinic.
Yeah, I was in last August.
Oh, you did a Ann Arbor. You did a course, some kind of course, right?
It was a sort of observership.
Oh, okay.
Very good. Brachial-plexus surgery.
Oh, okay.
It's very interesting.
Oh, okay. Very good. Okay, subarachnoid. You're gonna do subarachnoid bleeds, right, Naru?
Yeah. Yes.
Okay. Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, Florida. This is another weekly AFAN meeting of the African Future Neurosurgeons. And today we have the pleasure of having Naru, a neurosurgical resident from Morocco. And also we have another presentation by a medical student after that. He hasn't arrived yet, but let's meet the panel before we start. Hello, Marco.
Hello, John. Hello, everybody. My name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona, North Italy.
Frequent contributor here. Hello, Macindo. Macindo, how are you? Okay, go ahead, Macindo. I unmuted you. Oop, let's try again. One more time. Macindo, can you unmute yourself? There you go. Go ahead. Go ahead, Macindo.
Okay, I am Sindo. I'm Augusto Sindo from Mozambique, resident of neurosurgery here.
Okay, welcome, Macindo. Zimbabwe, right?
Mozambique, Mozambique,
Oh, I'm sorry,
Mozambique.
Mozambique. I'm sorry.
Mozambique.
Okay, very good. Okay, Naru, welcome. Could you tell a little bit about yourself before you present? And welcome. Thank you.
Thank you, John. Thank you. So I will. I am Nuruddin Bankol. I am. But I think you present me, John. I am currently now in internship in neurosurgery department of CHU of Tours in France now. So and welcome everyone to join with us. And I think I will share my screen if everybody is ready. Okay. Nice. Okay. You can see my PowerPoint. Okay.
Yes,
Can
good.
you see my screen?
Yes, it's good.
Okay, nice.
Yes,
So we can start.
Yes.
Okay, so today I will talk about spontaneous intracerebral hemorrhage. I will use this plan. I will do introduction. I will talk about the physiopathology, the diagnosis, clinical like paraclinical. I will talk about the classification of ICH, the etiology, the management, and also I would come and follow up and some key points and to conclude. About the background, spontaneous intracerebral hemorrhage defined as non-traumatic bleeding into the brain parenchyma, which can extend into the ventricle and into the subarachnoid space. The second most common subtype of it is on the second most common subtype of stroke. 5.3 million cases and over 3 million deaths reported worldwide in 2010. And it is also case fatality is extremely high, reaching approximately 60% at 1 year post-event. What about the epidemiology? The incidence of hypertension-related ICH is decreasing in some regions due to improvement in the treatment of chronic hypertension. Anticoagulant-related ICH like vitamin K antagonist and the newer oral anticoagulant drugs represent an increasing cause of ICH, currently accounting for more than 50% of all of cases. ICH affects more than 1 million people annually worldwide, and it is the deadliest and most disabling type of stroke. Uncontrolled hypertension is the most common risk factor for spontaneous ICH. And I want to make this important remark. I will not talk in this topic about subarachnoid hemorrhage because we should know that spontaneous ICH sometimes can include also subarachnoid hemorrhage. But today I will just talk about spontaneous hemorrhage intracranial. Primary prevention with antihypertensive medication is likely the most effective strategy to reduce the burden of ICH, although only accounting for 10 to 50% of all stroke in the USA is ICH cause a disproportionately high level of morbidity and mortality. In 2010 alone, 62.8 million disability-associated life years daily were lost compared with 39.4 million days lost due to ischemic stroke. Despite age standardized mortality rate from ICH decreasing by over 25% over the last 50 years, 3.2 million deaths were attributed to ICH versus 3.3 million deaths from ischemic stroke in 2013 alone. So it is equitable. What about the physiopathology? Primary ICH is typically a manifestation of underlying small vessel disease. First, long-standing hypertension leads to hypertension vasculopathy, causing microscopic degenerative change in the walls of small to medium penetrating vessels, which is known as lipohyalininosis. The pathological mechanism that underline it is the function of activation of systemic complement and cascade of coagulation. Following initial vessel rupture, the hematoma causes directly mechanical injury to the brain parenchyma. So we will have perihematoma edema development within the first 3 hours from symptom onset and peak between 10 to 20 days. Next, in the next term, blood and plasma products, immediate secondary injury processes, including an inflammatory response, activation of the coagulation cascade, and iron deposition from hemoglobin degradation. And also, we will have mass effect, ischemia, and toxicity of blood component are also responsible for brain tissue damage. So what about the diagnosis? The acute presentation of ICH can be difficult to distinguish from ischemic stroke. So the symptoms may include headache, nausea, seizure, and focal or generalized neurological symptoms. Findings such as coma, headache, vomiting, seizure, neck stiffness, and raised diastolic blood pressure increase the likelihood of ICH compared to ischemic stroke. That make us to do the difference between ischemic stroke and ICH. But only neuroimaging can provide a definitive diagnosis. So in addition to a prompt clinical story and neurological examination, we should make neuroimaging with a non-contrast red CT and specific. And you have to know CT scan is specific for ICH, and it is the key to early diagnosis. CT scan will reveal not only the location and size of the ICH, but also they can reveal also intraventricular extension, mass effect, hydrocephalus, and early signs of herniation. Like you can see here, that is an example of ICH cases with different locations that we can have. Here it is putamen localization, T thalamus localization, T subcortical arachnoid brain space location. Here it is the pons in the brainstem. Here it is the cerebellum location, and here it is the lobar, temporal lobe. And I will talk more about the etiology, about the type, depends the type of location of hematoma. You can also have an idea about the etiology. So we have also delayed MRI, who is better utilized as an adjunct tool to aid in determination of the underlying cause of the ICH, so such as cerebral amyloid angiopathy, cavernoma, and tumor who bleeding, tumor who bleed. The CT angiogram is very also sensitive for identify associated vascular abnormality and contrast extravasation as a spot sign. Contrast extravasation during angiography is associated with ongoing bleeding and increased mortality. The risk of contrast extravasation is increased with extreme hypertension, depressed consciousness, and large hemorrhage. So it is very, very useful to pay attention. It is not all the patient we should make the CT angiogram, because in large hemorrhage, you don't have any benefit to go to done CT angiogram. So hematoma volume can be estimated on head CT scan using the ABC under 2 methods. So sometimes when after made CT scan, we should, sometimes the neuroradiologist give us the volume of hematoma, but we should also know how to estimate it, the volume. So like you can see here, that is one CT scan axial view, one slide of CT scan axial view. You can see here this frontoparietal hematoma, and you can see here the number A. It is the diameter on the axial slice with largest hematoma area, so to there to here, and B, it is the maximal hematoma diameter perpendicular to A, and C is the number of CT slides. Because if maybe you have 10 CT slides, you have to, because when our radiologist give us the CT scan, we have also maybe 10 or 20 CT slides with hematoma. We can have 20 CT slides, but maybe in the 20 CT slides, just 10 CT slides, we have hematoma. We can see hematoma. So we should take the number of CT slides with hematoma and to multiply it by slide thickness. Sometimes it is maybe 5 centimeters, maybe 10 centimeters. We should multiply by slide thickness, and to addition and to do under 2 to have the volume to the volume of the hematoma. This method of hematoma volume calculation will variable between examiners has been shown to be effective for clinical decision making. We will see why in a few moments. So, what about the classification of ICH? Spontaneous ICH can be classified as either primary ICH or secondary ICH depending on the underlying cause. Primary ICH accounts for 70 to 80% of cases and is due to spontaneous rupture of small vessel damaged by hypertension or amyloid angiopathy. Primary ICH is also classified by location as lobar versus non-lobar and supratentorial versus infratentorial. So lobar ICH is commonly the result of cerebral amyloid angiopathy, CAA. Amyloid deposition is small-sized to medium-sized cortical perforator may lead to the rupture of these vessels, resulting in asymptomatic microhemorrhage or symptomatic lobar hemorrhage. But the non-lobar ICH is most often the result of long-standing high blood pressure, resulting in lipoamylosis of small perforating arteries of the basal ganglia, thalamus, pons, and cerebellum, leading to deep hemorrhage, often with extension into the ventricle. The most common location of hypertension ICH are the putamen, thalamus, subcortical white matter, pons, and cerebellum. The secondary ICH is associated with a number of congenital and acute conditions such as a vascular malformation, tumors, coagulation disorder, use of anticoagulant and thrombolytic agent, cerebral vasculitis, drug abuse, and cerebral venous thrombosis. That is the secondary ICH classification. So what about the etiology? Chronic arterial hypertension, cerebrovascular amyloid deposition, and coagulopathy as the most common etiology of the ICH. The use also of oral anticoagulant, especially vitamin K inhibitors like warfarin, has increased coagulopathy-associated ICH in recent years, accounting for more than 50% of all of cases. Psychosocial, ethnic, and economic factors play a role in the prevalence of cerebral hemorrhage, with ICH being twice as common in low-income and middle-income countries compared with high-income countries. Other identified risk factors for ICH include age. Each decade from 50 years of age is associated with a twofold increase in the incidence of ICH and an elevated alcohol intake also. Etiology of ICH to always consider include intracranial aneurysm, typical presenting as subarachnoid hemorrhage with ICH. Arteriovenous malformation, ICH is the first presentation of AVM in 60% of cases. That is the difference between manifestation about MVA and aneurysm. Cerebral venous sinus thrombosis and venous infarction also. Brain tumor, less than 5% of all ICH cases, including cerebral metastasis, and primary CNS tumor and drug of abuse. Because of the different etiology of ICH, a rapid and accurate diagnosis of the underlying etiology of ICH is essential to direct appropriate management strategies. What about the management? ICH is a medical emergency requiring urgent therapy given that more than 20% of patients experience a decrease of 2 or more points in their Glasgow coma scale after the initial assessment by emergency medical service. In addition, 50 to 23% of patients have hematoma expansion and neurological decline in the first several hours. Stabilization of airways, breathing and circulation. So airway, breathing, and circulation, ABCs, is essential for preventing secondary injury from hypoxemia, hypertension, and hematoma expansion. Intubation for air protection is indicated in patients with Glasgow coma scale less than 8 or significant respiratory distress. So that is one algorithm I find in literature. When you suspect ICH, sometimes you can brain attack activation into single alpha page stroke team. So initial evaluation, check and secure airway, breathing, circulation, peripheral for intravenous placement, and blood draw for coagulation, supplemental of oxygen, continuous pulse oximetry and cardiac monitoring, physical and neurological exam, and you should done CT scan, non-contrast rate CT. So when we have on CT scan evidence of ICH, we should done labetalol, or I think in our department we use nicardipine infusion to when that is needed, and emergency reversal of coagulopathy if we are in the case of coagulopathy, and sometimes mannitol or hypertonic saline for mass effect or inhibition. And now we can go to see if we have retain surgical indication, yes or no. If it is yes, neurosurgical should be consulted. Ventriculostomy for severe IV, AVH, and hydrocephalus should be made. Craniotomy for light cerebellar or temporal ICL should be done. And also admit to no ICU and ICH order set. If we don't, anyway, if we don't retain surgical indication, patient should go directly to the ICU. That is the protocol of reversal coagulopathy. I will not take time more than that. Medical management should be focused on blood pressure, ICP, fever, seizure, and glucose. Because for person with systolic blood pressure more than 150 millimeter of mercury, and 220 millimeter of mercury, treatment with a target of 140 millimeter of mercury can be a safe and effective method. And for those persons who with systolic blood pressure superior than 220 millimeter of mercury, aggressive blood pressure reduction with a continued intravenous infusion of blood pressure lowering drug such as nicardipine should be considered. About the ICP, person with decreased level of consciousness can be treated by ventricular drainage of the hydrocephalus if needed. Hypertonic saline or mannitol can be used appropriately. About the fever should be treated with antipyretic medication and external or internal cooling method to prevent poor outcome. About the seizure, clinical seizure should be treated with antiepileptic medication, as should electrographic seizure accompanied by change in mental status. And it is very, very important to done regular monitoring and control of glucose is very essential to prevent both, because hyperglycemia, it is not good for brain. Hypoglycemia, it is not also good for brain. So what about the surgical management? I will talk first about infratemporal hemorrhage, because infratemporal hemorrhage is so emergency cases done supratentorial. So infratemporal hemorrhage, emergent surgery is strongly recommended in patients with cerebellar hemorrhage with symptoms of neurological deterioration, because all of them, we know that the posterior fossa has little free space. Cerebellar hemorrhage easily bring about brainstem compression, ventricular obstruction, hydrocephalus, and eventually high fatality. So patients with a cerebellar hemorrhage more than 3 centimeters in diameter, or person in whom cerebellar hemorrhage is causing brainstem compression or hydrocephalus can get better outcome with surgical decompression of hematoma evacuation. The role of the surgical evacuation is to decrease mass effect related to the presence of blood, as well as to minimize secondary injury. Initial treatment of cerebellar hemorrhage with ventricular drainage alone rather than surgical evacuation is not recommended due to insufficiency for ICP control, as hematoma evacuation of a brainstem hemorrhage may be harmful. In many cases, brainstem hemorrhage is usually managed conservatively, and sometimes if you have hydrocephalus, we can perform shunt, external shunt to control raised of ICP. The beneficial effect of surgical management of supratemporal ICH remain controversial and should be restricted in specific situations. Although several randomized trials have compared the efficacy of surgical management and conservative medical management, they have not shown significant benefit of surgical management on mortality or functional outcome. The international surgical trial in intracerebral hemorrhage stitch was conducted to prove the superiority of yearly hematoma evacuation within 24 hours of randomization over conservative medical treatment. In these stick trials, it was suggested that yearly surgery could be beneficial in certain patients with superficial lobar hemorrhage, but there was no overall statistically significant difference in the mortality or functional outcome between the yearly surgery and initial conservative treatment group. So in 2013, the results of the stage 2 trial were published. So that is another study after the first stage study in 2010. The stage 2 trial compared the outcome of yearly surgery and initial conservative treatment in conscious patients with superficial lobar hemorrhage of 10 to 100 milliliters within 1 centimeter of the cortical surface with no high intraventricular hemorrhage, and who were admitted within 48 hours on the onset of symptoms. And thus, these two large randomized trials failed to prove the benefit of yearly surgical management with hematoma evacuation over initial conservative treatment. Hematoma evacuation might be considered as a life-saving measure in patients with supratemporal hemorrhage showing neurological deterioration. If you don't have any neurological deterioration, if the hematoma is not lobar and accessible for surgery, maybe it is better to treat that conservatively and medical treatment. So previous studies have reported that patients with a Glasgow Coma Scale score less than 8, significant midline shift, large hematoma, or medically intractable ICP might benefit from decompressive craniectomy. Therefore, despite the failure of large clinical trial, it should be noted that decompression surgery with or without hematoma evacuation might be helpful in reducing the mortality rate in this specific situation. So what about the role of minimally invasive surgical evacuation of ICH, sometimes with stereotactic or endoscopic aspiration? Nowadays, it is not so clear, and many controversial we have many controversial nowadays about minimally invasive surgical evacuation. Several studies have suggested that minimally invasive surgical evacuation might be less invasive and have better outcome compared to a craniotomy approach. But in a randomized clinical trial conducted in China, needle aspiration of basal ganglia hemorrhage improved the 3-month functional outcome without significant improvement in mortality rate compared compared to medical management alone. So what is the timing to decompress surgery? On the basis of the subgroup analysis performed in the stage 2 trial, surgery, if needed, should be considered within 21 hours of ictus for better outcome. One meta-analysis indicated that there was improved outcome with surgery is if randomization was undertaken within 8 hours of ictus. Another prospective study reported that surgical hematoma evacuation within 4 hours of ictus was complicated by rebleeding, indicating difficulty with hemostasis, although more evidence is needed to determine the timing of surgery. Surgical management should not be delayed if patients show neurological deterioration, and surgical management can be beneficial in this situation. Always when patients show deterioration of neurological status, we have hematoma lobar who is accessible for surgery, we should operate. What about intraventricular hemorrhage? Intraventricular hemorrhage is usually related to deep-seated ICH in the basal ganglia and or thalamus. IVH is a crucial determinant of poor outcome in patients with ICH. Recently, ventricular catheter insertion with thrombolytic agents has been studied to overcome the inefficiency and difficulty of maintaining catheter patency. The clear IVH trial clot lysis evaluating acceleration resolution of IVH compared treatment with recombinant tissue type plasminogen activator RTPA and placebo in patients with IVH attributable to spontaneous ACH. Patients treated with RTP had lower ICP and less frequent ventricular obstruction. The symptomatic rebleeding rate was not significantly different between the two groups. So we have 12% in the RTPA group to 5% in the placebo group. The median 30-day modified ranking scale score and mortality did not differ either. While RTPA seemed to have an acceptable safety profile in the treatment of ICH with AVH, its efficacy and safety remain uncertain. Data from a well-designed phase 3 clinical trial such as a CLEAR 3 will be needed to fully evaluate the safety and efficacy of this treatment. So in my department, we don't do that. What is the indication? Depend situation when we have cerebellar hemorrhage with neurological deterioration associated with brainstem compression or hydrocephalus, we should evacuate hematoma. Supratentorial hemorrhage with neurological deterioration, we should evacuate hematoma. Supratentorial hemorrhage with Glasgow coma scale score less than 8 and significant midline shift and large hematomas, medically intractable ICP, we should perform decompressive craniectomy. And also hydrocephalus with or without IVH, we should done ventricular drainage externe. What is the end? We should always remember about the rehabilitation, because rehabilitation is strongly recommended in patients who have survived the acute stage of ICH but are discharged from acute care hospital with disability. The main principles of rehabilitation for patients with ICH are similar to those for patients with ischemic stroke. It has been repeatedly reported that the improvement of functional outcome was significantly greater in patients receiving rehabilitation compared with those receiving standard medical care. So on the basis of our knowledge about stroke recovery, rehabilitation is recommended to be started as early as possible and should be continued in the community as a part of a well-coordinated program of accelerated hospital discharge and home-based resettlement to promote ongoing recovery. It is very important. So what about the outcome and follow-up? ICH is the most debilitating and deadly type of stroke. A number of factors may affect outcome after ICH, including hematoma volume and location, hematoma expansion, age, GCS score on presentation, intraventricular extension and anticoagulant use. Also, most patients die from ICH within the initial hospitalization due to presumed poor outcome leading to withdrawal of care. Multiple grading scale exist that allow for evidence-based risk stratification in the acute phase. First, we have the ICH score, who predict 30-day mortality using features such as the age, ICH volume, and the presence of IVH with higher score associated with worse outcome. We have also in second time the FUNC score, that means functional outcome risk stratification, who predict functional independence rather than mortality at 90 days. The higher the FUNC score, the greater the chance of the patient recovering functional independence. Like you can see here in this figure, we can see here, ICH score point, the total is 6. So it is dependent about GCS score, ICH volume, AVH, infratemporal origin of ICH, and the age. So the GCS score, if you have patient between 3 to 4 GCS, ICH score, it is a point, it is 2. Between 5 and 12, it is 1, and between 13 and 15, it is 0. If the volume of ICH is more than 13, you have 1 point of your ICH score point. Less than 13, it is 0. You have associated of IVH, intraventricular hemorrhage, yes, 1, no, 0. Infratemporal origin of ICH, yes, it is 1, but no, it is 0. You have patient age more than 80, you have 1, and less than 80, you have 6. And you can see here the diagram, the ICH score and 30-day mortality. About, we can see here, ICH score to 0 to 1, you have less than 20% of mortality. ICH score between ICH score of 2, please, ICH score 2, you have like 13% of 30 days mortality percent. ICH score 3, so more you go, the higher ICH score is, outcome is so bad, very so bad. Like you can see here, ICH score 5 to 6, you have like 90% of death, of mortality. And another study showed that here, according to total score, you can see here, total score 0, mortality is between 0 to 13 to 10%. ECH score 1, mortality is between 7 to 13. 2, 13 to 44. And ICH score 3, you have mortality between 56 to 78. And when you have ICH score 4, the mortality is between 70 to 100%. And ICH score 5 to 6, it is 100 mortality, 30-day mortality you will have. And here it is the functional score stratification that take about the volume of the hematoma. Oh, sorry, the age of the patient. So a young patient inferior than 13, you can have 4, like functional recovery. Between 13 to 60, you have 2. Superior than 16, it is 0. Age and the inferior than 70, it is 2. 70 to 79, it is 1. Age superior than 80, it is 0. ECH location lobar and deep please, sorry, this it is the volume of hematoma. This is the volume of hematoma, and this is the age. Here it is the location, and when you have lobar location, it is 2. When it is deep, it is 1, and infiltrate it is 0. GCS score also superior than 9, it is 2, and inferior than 8, it is 0. And pre-ECH cognitive impairment, before if you don't have any pre-ECH cognitive impairment, you have 1, but if it is yes, it is 0. So the total of functional score, it is 11. So if you have a good score of functional score, you have it is the greatest the chance for person to recovery and have good functional outcome. So what is the key point? The key point, it is spontaneous ICH is a neurological emergency associated with high mortality and morbidity. The key of management issues include prompt etiologic diagnosis, reversal of anticoagulation, consideration of surgical management, and control of blood pressure. The clinical scenario and local practice will influence choice of therapeutic environment and rehabilitation as soon as possible. It is very important to think always about the rehabilitation when it is possible. So in conclusion, in order to overcome the high mortality and morbidity, it is recommended that patients with spontaneous ACH should be taken care of in a well-organized, specialized stroke care facility with a multidisciplinary team approach. That is the fourth big reference that I use to make this topic, and thank you for your attention.
Thank you very much, Naru. Thanks for taking the time on your day off, probably, to give us some neurosurgical education. Let's meet a few of the panelists that came in a little bit later. Hey, hello, Zolo.
Hello, Dr. Ben.
Yeah, say hello to Naru.
Yes,
Hi.
Dr. Nuru. Hello, everybody. Hello, everybody.
Welcome.
Sorry, I am on call. I'm on call, and I could not connect myself at the time of the meeting.
No,
But
Okay,
it's
very
always
it's
a
okay.
pleasure
You
being
will
with you.
that after.
Very good. Welcome,
All right.
Zolo. Arsene, welcome back. Arsene, can you please introduce yourself? Just unmute. Yeah.
Hello, Dr. John. How are you?
Yes. Could you tell us about yourself, please?
Hello, Dr. John. How are you?
Yeah, you're a medical student. Where are you? Could you tell us about yourself?
Hello, Dr. John. How are you?
Yeah.
Do you hear me?
Yes, I do. Could you please introduce yourself?
Yeah, do you hear me?
Yes, I do. Can you hear me? Maybe not.
Yeah. Let's introduce myself. I'm a medical student in the last year in Republic Democratic of Congo.
Okay, welcome,
I'm a
welcome.
medical student, as I said already, and it is a pleasure to be back on this panel.
Okay, I'm sorry if I missed that. Okay, very good. Stefan, do you want to say hello and introduce yourself, please?
Okay. Hello, Dr. Bennett. I'm Stefan Gembu, general practitioner from Cameroon.
Okay, welcome. Welcome. Okay, I have a few non-neurosurgical questions, but let's see if Marco or someone else has a neurosurgical question or comment. Any comments or questions, Marco?
No. First of all, I want to congratulate Noro. It was a great presentation and very complete and very updated. I just want to share my experience. In my casuistic, I prefer, obviously, if the patient is in a stable condition, to delay the surgery of a half day, 12 hours, 24 hours. That's why. First of all, because the patients sometimes when after the beginning of intracranial hemorrhage has a unstable clinical condition with high blood pressure, and this can complicate the surgery, create a brain swelling that sometimes complicate the surgery. Obviously, if the patient is going in in trouble, neurologically speaking, you're forced to perform craniotomy as soon as possible. But I prefer to delay. Why? Because I have more stable condition, and because the hemorrhage coagulates. So you have also an hemostasis, because the pressure of clots create a sort of hemostasis. So you can perform surgery like it was a tumor exeresis. You have just to remove the clot to perform a cortisectomy or open the sulc, remove with suction the clots. The hemostasis is very simple in this case. You have a very good control. Sometimes I also avoid, but in some cases, to use the Tabotam, because you just perform hemostasis with electrocoagulation, very few point of bleeding, and the outcome, in my experience, is pretty good.
Very good. Yeah, you know, Naru, do you see a high percentage of hydrocephalus associated with, or is it kind of a rare occurrence in intracerebral bleeds?
Hi, do you hear me?
Did you hear what I said, Naru? Do you see much hydrocephalus? You mentioned that can occur with an acute bleed. How is it pretty often you see that, or is this rare?
Yes. Do you hear me? Do you hear me, John?
Yes. Yes.
Okay. Of course, if you have cerebellar or brainstem hemorrhage, of course you can have obstruction of the way of CSF. So you will have hydrocephalus. Sometimes you have that, or if you have like depend the location that I told you, to cerebellar, and when you have thalamic or putamen subcortical hemorrhage, sometimes that going to the lateral ventricle, and that can make the obstruction. So you will have hydrocephalus. So in this case, you should perform external shunt to control the ICP raise. And I am also agree with Marco Meloni. I am totally agree with you. And obviously, sometimes we should very take careful. We should not go immediately to perform surgery. We should we should pay attention about the condition of the patient, the hemostasis condition, and if everything is okay, and if everything is indicated to go to surgery, then we will go to surgery. I am totally agree with you. And it's not in all cases we should perform the compressor craniotomy. I think I showed that the indication about the compressor craniotomy. So effectively, and when you perform your cortisectomy, you don't need to go so deep, because sometimes just perform the craniotomy, open the dura, the pressure, touch the hematoma, and the hematoma come alone. So you should just take what it is come and let what you should not go in deep to evacuate it. You should be superficial like as possible. So I am agree with you. That is the recommendation. So thank you for your comment and your approach.
Yeah. Go ahead. Does someone have something to say? Yeah, I just had one comment, Naru. I know, of course, you want to get a CT as soon as possible. Now, have you ever been in a situation where you don't have a CT and you have a patient that probably has a bleed, and you have to go ahead and do something without the CT? Ever been in a situation like that?
Oof.
That's a tough one, huh? Yeah.
In my experience, no.
No. Okay.
Yeah, always have CT scan.
Right. I imagine most
But
parts
I
of the world.
know I know I don't know, maybe in 20 or 30 years ago in low middle income countries and
Right.
the area that they don't have CT scan,
Yeah.
depending the clinical presentation, some people go to exploration, craniotomy exploration. Some people do that, but nowadays, no, we should perform CT scan.
Right. Wait for the CT.
Yes.
Yeah, that shows how old I am. You know, yeah. Okay, Ulrich's here. Good. Do you see, and but this is a question for both Marco and Naru. Do you see a trend of getting more common, of being invasive with ICH, with the intracranial bleeds, or do you see the same level of intervention? Or do neurosurgeons tend to be more aggressive now? No, about the same, you think?
Well, I think from my point of view, it's become more or less the same.
Okay, same. Okay.
Probably in the past time, but I think I was pretty young. There was also a way to perform craniotomy even for deep hemorrhage, but now we know that for I would say nucleocapsular hematoma, surgery should be avoided as much as you can. So I think the level is the same one, usually the same one. Fortunately, from our years, we have more tools to analyze the etiology of hemorrhage. In the past time, this was not possible, but now we can analyze if there is a tumor behind or is a arteriovenous malformation. So you have more tools to organize the surgery. In fact, in my experience, I just see one case where the removal of intracranial hemorrhage has an aneurysm in the deep. I remember perfectly with my own eyes removing the clots, and suddenly a strong bleeding. In fact, it was an aneurysm deeper.
In what cases, yeah, of course, everyone gets a CT, but and when do you get an angiogram? When do you consider going and getting an angiogram? And again, I'm not a neurosurgeon, so.
Okay, I will let Marco answer you.
Okay.
Continue, Marco.
Well, obviously, when the hemorrhage is spontaneous, first step, and second, the anatomical location of the hemorrhage. If you have an hemorrhage that is close to sylvian fissure, and you have people with risk factor, like could be high blood pressure history, I perform an angio CT scan immediately because I exclude an aneurysm. That's the case. Or patient with a particular strange hemorrhage. First of all, when you have a ring edema around, and hemorrhage is of the symptoms started a few hours ago, I suspect this edema is too early for a spontaneous hemorrhage. Probably there was already something into the that caused the hemorrhage. That could be a tumor. So I think there's there are aspects that put me to delay the surgery and check if there is some problem. Obviously, the rule is one: if patients deteriorate, cause increasing hemorrhage, perform surgery.
Oh, right. So you gotta
CT scan, angio CT scan, and then perform surgery. At least, as told neuro, to perform the compressive craniotomy and relieve the intracranial pressure. Then you can start with a new surgery if there is a arteriovenous malformation or something like that. But first of all, save the patients and then you can plan a new surgery, the more sweet surgery.
Well,
I'm totally agree with you, John. With you, Marco. It is typical. It is logical what you said, and we should think like that. It's because that's why it is important to achieve, because the patient is not just the CT scan. It depends the presentation of clinical presentation, because it is not all ICH hemorrhage will be present in the same clinical form. Like you say, of course, if you have ICH with subarachnoid hemorrhage, you should also think, oh, maybe this is not typical ICH. So before and sometimes the hematoma is not always big. So before you should go to do surgery, you should go to do maybe, like you said, to done different if it is a tumor or if it is abnormality, vascular abnormality. You should go to perform MRI or angio MRI or CT angiogram directly to know maybe it is MVA, AVM, or maybe it is aneurysm. Because like you say, I remember in my department before I left Morocco, some big hematoma, you don't know what inside. That's why it is very, you should be careful to don't go so deep, because if you go so deep, maybe some clot like hematoma just do the coagulation. So don't remove all, because if you go to remove all, if you have AVM, you will have a secondary injury, bleeding. You don't have microscope, maybe it is you are in shift, catastrophic. Sometimes you can lose your patient if you don't have a senior with you who can come quickly to do something. You don't know which is the situation of the aneurysm, because before to go to clip aneurysm, you should know, you should planning, you should do many things. So you don't have that. So we should take care about that. And every however we should go to operate, we should pay attention about ICH surgery. That is my view.
That's correct. That's correct. In fact, the anatomy is very important in this case. So always have in your mind the anatomy of the vessel. I remember always the case because sometimes the aneurysm, not always, more often they cause subarachnoid hemorrhage, of course, but sometimes they cause intraparenchymal hemorrhage, probably because the patient has already had some bleeding.
Sometimes MCA. Sometimes MCA cause that, yes.
Yeah, some EDH and aneurysm rupture into the pia mater and cause intraparenchymal hemorrhage. So always consider the anatomy. I always remember a case with a patient with spontaneous intraparenchymal hemorrhage without the subarachnoid hemorrhage at all, but it was interhemispheric. So I said to myself, the radiologist, please perform angio-CT because it's very strange aneurysm there. In fact, pericallosal aneurysm.
Communicant anterior, I think, maybe.
It was a pericallosal because it was not exactly in the genu, but a little bit over the genu. So.
Okay, good. Oh. So you perform interhemispheric approach.
That's correct. That's correct.
Nice.
Hemispheric and close peric isolate the pericallosum and then clip. It was very little, but it was suitable for clipping.
Good.
Now you both mentioned you got to monitor the neurological status to see if it's worsening or getting better, and this kind of is a benefit for the students too. When you go to the bedside, you're obviously checking mentation, how the patient's talking, thinking, and what other quick neurological, when you quickly walk in the room, you're busy, you want to check the patient. What do you do exactly in your exam, your neuro exam, to check the patient to see if they're getting better or worse?
I don't understand your question.
Okay, well, like when you to evaluate a patient to see if they're deteriorating neurologically or getting better, what sort of physical part of the physical exam do? You grab their hands and squeeze them, or you ask them to squeeze it, or you have them move their legs, or what
Okay. First of all, you have to should
a quick exam, like you're busy.
First time the pupils of the patient, if you don't have anisocoris or if you don't have fixated pupils, unilateral or bilateral, you should first time. And also, if the patient is not intubated, you can also done your GCS scale exam to know, and you should perform another CT scan to see or Doppler transcranial to see.
Correct.
Okay.
Exactly.
Okay, students, you guys have any questions or comments? Stefan or Arsene or Zolo? Go ahead,
everyone,
Stefan.
Please excuse me for being late. I'm in call. So
that's okay. That's okay.
Okay. My question is about the surgical approaches. If it's possible, taking the perihemorrhagic edema, cystinostomy can be an approach for the intracranial hematoma deeply, atypical intracranial hematoma. Can we consider cystinostomy?
Did you get that question, Nuru?
Okay, I understand what you want to say. You think maybe if we should to fight, you mean to fight edema, we should perform system.
Yes.
But like I told you, it is depends the location of your hematoma. Because
for atypical hematoma, I say,
yes,
like
no,
intravascular hematoma.
We should not go to perform cystinostomy for all the cases. No, if you have temporal, lobar temporal hematoma and it is so big, yes, it depends when you evacuated hematoma, you can go deeply with microscope, maybe to open Sylvian fissure to release some CSF to help the decompress of brain. We can do that, but it depends on hematoma, because if you just have and also if you have cerebellar hematoma, you will not go to do cystinostomy. You should do after evacuate hematoma shunt, external shunt. It depends the location, and it's not all of case you should do cystinostomy. Cystinostomy it is for trauma.
Okay,
here we are in case about ICH, it is bleeding spontaneous without trauma. So cystinostomy should be considered depending on the location. I don't know what you think about that, Marco.
Well, usually when I perform infra-occipital craniotomy for cerebral hemorrhage, if I see the cerebellum there is a large aneurysm, large hemorrhage, so I preview for cerebral swelling. Usually, first of all, I perform a craniectomy, so I don't put the bone again. But usually I open also the cisternal magna that can relieve the give more space and relieve the infra-occipital fossa pressure.
Okay. Yes.
Very good.
I understand. Thank you.
You're welcome.
Okay. I'd like to thank you very much, Naru, for taking time out to make your presentation, and thanks, Marco, and the students for all coming. And Ulrich there. Ulrich, are you there, or you just step away?
I think
I am.
Oh, okay.
I think Arsene wants to talk. Arsene wants to.
You want to say something, Ulrich? Want to say hello?
Yeah. Hello, Dr. Jordan.
Yes, go ahead, Arsene.
Go ahead.
Yeah, I have a question.
Go ahead.
My question is concerned when we are in context of limited means and we have a poor history, we don't know to make a difference between a ischemic stroke and ICH. What are the approach we can do in order to save the patient?
CT scan first table. You should.
But we have no ability to do a CT scan.
Oh.
We have a poor history. So what are the attitude?
Send the patient in ICU.
ICU and
Just
monitor, right?
Yes, ICU. But it is shameful to don't have CT scan nowadays. Also, you should make that. You should make something, and I don't know. Maybe after to transfer the patient in another center. After
Right.
you stabilize, you stabilize the patient. But you should send him in good center where he can make the CT scan and good management.
You know, it's the same in the United States. If they have a patient in a small hospital and that's got neurological damage, they'll transfer the patient immediately to a bigger hospital with the equipment, with the backup, with the surgeons and the operating team. They won't touch a patient that's a neurosurgeon won't come to such a small hospital because there's no backup equipment if they have to go to the OR. So hello
everyone. Yeah, hello everyone.
Yes,
hello Ulrich.
Yeah,
are those headphones or earmuffs?
Yeah, headphones. I was only able to catch the end of the presentation, but I trust Dr. Nuru to always come up with the goods. He always delivers, so I'm sure that'll be fine. The question by Asen, I will join everyone on that. So if you're thinking, someone needs to mute the mic. If you're thinking, if you want to take care of that patient and you're thinking about the best outcome for that patient, then the only thing you can do is recognize that you don't have the means for that patient and then send the patient to a place where you can take care of the patient. And I think in Bukavu, you have a neurosurgeon working there, Dr. Patel. So the best thing your center can do is get in touch with him and then call him, tell him you have this patient and send the patient to his hospital.
Mm-hmm. Yeah, and present the patient essentially. So, okay, very good. We'll wrap this up. Is DeWin stopping in? Do you know, Ulrich, if DeWin is coming?
I don't think so. So we can wrap it up.
Okay, very good. Okay, thanks everybody for coming. Once again, thanks Nuru and Marco and all the students. And we'll see you next week.
Goodbye.
Next week.
Okay, next week.
Yeah.
All right.
Okay. Thank you. Okay.
Nice to see
you. I'll stay here. The win went. Okay, Arsene, what year are you?
Yeah, I just want to congratulate Dr. Dean for his presentation, and I will also want to ask if Doctor can share his presentation with all of us, because we didn't catch all the presentation.
Okay, normally I think we have, normally you can see that in YouTube, I think. But anyway,
yes. We're gonna edit this video and it'll be on YouTube.
See that on YouTube, and also you can send me in. See with Ulrich, we have one group WhatsApp. You can send me your emails. Anyway, I will try to send that in your emails and after in the group, because now I do that with my laptop. So after I will take the phone and to send that in the group.
Well,
okay, and is it possible to me to send you my number and you can add me in the WhatsApp group?
Yes, send that. Yes. Ulrich, please.
Aren't you, Asen, aren't you in the Future African Neurosurgeons group?
You are
not
not
yet.
Okay, please.
Okay, I'll send you the link.
Okay, good.
Okay, thank you, Ulrich.
Ulrich will send you the link.
Okay.
Good.
You know,
I'm grateful.
You know, Arsene, the value of these webcasts are meeting people like Nuru, meeting them and making connections. It's valuable. It's valuable.
Yes.
You'll see in the future too.
Yes.
So
Okay, how are you doing, Ulrich? I am so sorry. I miss Kinshasa meeting. I'm so deeply affected about that. Just for 24 hours, the child is. I am so crazy.
Yeah.
But it is maybe God don't want me be there because I have a ticket, I have a visa, but I should have because now I am in France. My passport was in Embassy of France, and they told me tomorrow it is they don't work, so I should wait Monday. But me, I have flight Saturdays to go to Kinshasa.
Oh my goodness,
So
that's just terrible.
everything is
Oh,
catastrophe.
man.
But anyway, I will.
Oh, there'll be other chances, definitely.
Yes, it is. It is not
I
on
think
my
Dr.
power.
Sene will be organizing a research
Yes, I
course
see
in
that it
Guinea.
was
Yeah,
beautiful and amazing, and I am so
yeah, it was a great event.
proud about all of you and nice. And I think we should now take the grab on the Cannes Congress. It is important.
Yes, yeah.
This I will not. Of course, I will be there. I will be there. Yes.
Okay, yeah.
How is the program in USA of Harvard? It is going well.
Oh yeah, everything's going well. We have a
Finish?
few
Because you have to finish to start residency in neurosurgery, dear.
Oh yeah, don't worry about that.
Okay.
Don't worry about that.
I'm so excited for that. I know you will be the great resident and super resident in neurosurgery.
Well, thank you so much.
Start. Nice.
You know, we televised the ICRAN from Pakistan.
No, you do great job. I don't know how you do that, but it's
well. You know what? Talking about networking, I met the boss of Ulrich, the head of the neurosurgery, the global initiative.
Yes.
Yeah, and he presented virtually from Harvard. He stayed up at 3:30 in the morning and presented to Pakistan about
I woke up to that.
Did you see it?
Yeah, I saw it.
Yeah. Okay. Good. Yeah, he seems to like the platform. He was amazed. He said, "Wow, this is just like being there."
No, it is a great. I was attending in ICRAN last year in Napoli. After months, it is very, very great conference, ICRAN, and I recommended that for you if you have in your courses, if you have time to attend it in ICRAN, because you will see big bars about global things and the new recommendation about trauma, about many things. It is a great conference.
Yeah.
And,
they talked a lot about the global initiative at this conference. They had one section of it. You probably saw it, right? That was a good section. But they had some good names there. Really good names.
Yeah, they did.
Good presentations. So.
Well done. Yeah. So I will let you here. It is so cold here. I should go out to take something.
Okay. All right. Thanks, everybody.
Yeah. Bye. Hello,
thanks,
Dr. Meloni.
Thanks, Marco. Thank you.
Marco, maybe I will come to Italy. Now I am in France. It is not so far, so.
That's right. That's right. Just a train ride away.
Yes.
When you want, you're going to be my host when you want. I will be very glad.
Okay, I will let you know so soon. Okay. Goodbye.
Okay, everybody. Bye-bye. Thank you.
Yes.